We are thrilled to be here. We've really wanted to come and talk to the medical residents for a very long time. This is information that we feel is so important, and so we are really looking forward to sharing this with all of you. So in the interest of time, I know we have a lot to get through, and we don't have a lot of time. I'm going to turn the floor over to Greta, who is going to go through several slides. And then with whatever time we have left, we would like to open it up for questions and hopefully have a discussion. So, Greta.
All right. And also, this is the first time we've done this training. We kind of want to get your feedback. We've talked to a bunch of different people to see like what material would be useful, but I'm just going to pass around blank paper, and if you want to write down whatever thoughts you have and give them to us at the end, that would be super helpful. So, thank you. So I'll just put in a quick plug for Open Aid Alliance. Like she said, we're a nonprofit organization here in Missoula, and one of our primary things is that we operate Montana's only sanctioned above ground syringe exchange program, or SEP as we call it. And we do like HIV, Hep C, STI testing and prevention counseling and pregnancy testing and things like that. We have like a housing assistance fund for people who are HIV positive. And then we just got this really awesome grant, so we'll be opening up a treatment center eventually that sort of operates on like a harm reduction basis. And we'll kind of get into what that entails. But I think we'll just jump right into people who inject drugs, or PWID, and healthcare. It's been proven time and time again that people who inject drugs are disproportionately affected by illness, which makes sense. Injecting drugs is incredibly dangerous and risky. But they're accessing services, especially primary care services, way less than the general population. They often rely on like self-treatment of things and emergency facilities to get all of their health care. And so also like addiction medicine is kind of seen as like this really isolated specialty, but addiction is like everywhere. You guys all know that. You've seen it probably every day in your practice. So we kind of just want to be able to provide you with like the tools that you might be able to employ in dealing with this population. And we just also want to acknowledge the super difficult position you guys are all put in treating these people. They have often really complex medical complications, and you're also kind of trying to like deal with their mental health disorders and substance use disorders, and then that in the midst of like pain management, the opioid crisis. It's a hugely complex, challenging job, and you guys do a wonderful job. We have a lot of our clients that go to you for their medical care, and we just want to thank you for the amazing care that you've provided, and we hope to be a resource to you guys and kind of build a relationship with you, because we send a lot of our clients to you, and we know they're super challenging, but you guys do a really amazing job, so thank you for that. And I know that you guys probably hear about stigma all the time, and you're maybe sick of talking about it, but I think when talking about this population, we need to sort of mention stigma and how quickly stigma can actually turn into discrimination when we're like talking about healthcare or any sort of public service or anything like that. So just to be cognizant of that. And often, you know, these substance use disorders coincide with mental health disorders that manifest as these behavior problems. They may sort of mask the guilt and shame that a lot of these people feel, but it's just really important to still be kind of cognizant of that. And I know you guys all know this and do a great job of it, but I thought I would just kind of touch on that. So one of the main tools we'd like to kind of introduce to you guys, and you probably use this on a daily basis with things that are maybe a little more familiar to you, like cancer prevention and like sexual health and alcohol use and things like that. You probably are subconsciously employing this every day, but we kind of want to introduce this principle of harm reduction in the context of drug use to you, so you can start like consciously using it. It's basically just the idea that we're never going to eliminate drug use. It's always existed, it always will exist. So instead of having this like war on drugs mentality, maybe working to reduce the harmful consequences of that. And there's a lot of different ways that we can do that. And it's kind of this person focused. And it's really emotionally and mentally and challenging, and kind of challenges your compassion, and is frustrating sometimes to care for these people who have these substance use disorders, especially if they have behavioral issues along with that. But just trying to focus on the person rather than the behaviors sometimes is helpful for me, I know, especially. So this kind of just shows like the traditional view of drug treatment in general. I mean, we're focusing on people who inject drugs, but I think this can go to all substance use disorders. It's basically like, you can either force them into rehab or you can just let them continue on whatever path they're on. And oftentimes the coerced treatment goes back to chaotic and dangerous use, and we just want to kind of start moving away from this and make use of this drug use continuum. And I guess the main takeaway from today, if you get anything out of this, is just there are a million different places for intervention. It's not just abstinence and chaotic use. There are tons of different things you can do in between. And I don't want you to feel like you ever have to send a patient home like, well, they won't agree to treatment, so I did what I could, and that's that. So if you had an uncontrolled diabetic who's not complying with their insulin and they're drinking Mountain Dew and eating fast food every day, you're not going to send them home and be like, well, I tried, just because they won't go on a paleo diet and start training for a marathon. There are baby steps, you can take to get to the point that you want, and we just want to get you guys comfortable with using those. So we'll talk about a couple of those. So I would say the first step is talking about it, and it's kind of overwhelming, especially if you're not used to discussing injection drug use with people. When I first started at Open Aid Alliance, it was uncomfortable for me to say the word meth out loud. It was just I didn't even know how to talk to people, but I think just over time you get more comfortable with it, and I'm sure a lot of you are already to this point. But the first step that we like to talk about, and we use this in the Surge Exchange a lot, is just this statement of reassurance. And I think it does a couple things. First of all, it brings up drug use without having to actually accuse someone of it, and that kind of puts them in this defensive mood. So if you just give them one of these statements of reassurance, it brings it up in kind of a nice, easy way. And then it also takes away a lot of the paranoia and fear that they have, whether it's related to the drugs themselves or mental health disorders that coincide with the drug use. There's a lot of paranoia about legal issues. They're kind of a lot of times convinced that everyone's out to get them and they're going to get in trouble. So if you can just nip that in the bud before it even becomes an issue, I think that's really powerful. And then I know that healthcare providers, a lot of our frustration comes from denial of drug use when people won't admit to it. So I think this kind of helps your patient feel like they can admit that they're using, and then you can kind of go from there. So, and then the other thing is just asking them questions. A lot of people who are injecting drugs, a lot of people from this population often feel pretty isolated, and they're very rarely empowered. So if you can ask them their opinion, or ask them to explain something to you, it can be really powerful and make them feel like they have a say. And then the other thing it does, I think I've noticed this in the Surge Exchange, or when I'm testing people, it sort of evens out this perceived power dynamic that they see. They're a lot more willing to work with you if you show an interest and ask them questions. If they say a word that you don't mean or that you don't understand because there's so much slang and jargon associated with drug culture, and you ask them what it means, it really empowers them, and they're almost always really willing to talk and a lot more willing to work with you. So I think it just makes everything go a lot smoother. Just allowing your patients to be the expert on their own drug use is really important. So I guess, from here we'll go into just things to do with drug injection to kind of make you more comfortable and aware of what's going on. So these are all supplies that we supply in the Surge Exchange program. Obviously you have your clean needles, alcohol pads, sterile water. We have this from time to time. A lot of people who inject drugs get their water from really questionable sources, like the river or puddles or public bathrooms, and that's super dangerous. Things like that. Tourniquets. And then does anybody know what these are? These are basically, they're cookers. So they're instead of a spoon, we provide these. A lot of infection transmission can actually happen from the preparation of the drug. So we provide these so everyone has their own and they're not sharing with anybody. And then these, does anybody know what these are? These are cottons. I don't know if they have any other name really besides cottons, but a lot of times when you melt down drugs or prepare drugs, there's particulate matter or even contaminants in them, and so filtering the drug before it's injected is really important in preventing infection. So we provide these. A lot of people will use like cigarette filters or Q-tips or things like that that have like small little particles of cotton that break off into the bloodstream and can cause cotton fever. And I think it's like a lot of sepsis-like symptoms and can be super dangerous. So these are continuous strands of cotton, so this doesn't happen, and we provide these. So, yeah. And then obviously, I think that a lot of this goes without saying, but clean needles are super important. We provide these, and then in Montana, they can be legally obtained without a prescription, so pharmacies can give them out, but it's at the pharmacist's discretion. So we've run into a lot of issues with this. Like, there are certain pharmacies that like absolutely not, and then there's a couple pharmacies that are super willing to work with people and sell like a box of 100 needles for like $13 or something like that. But the primary source of clean needles in Missoula are from us at the Syringe Exchange, and we're happy to provide that service because it cuts down on all of these infections. I don't need to go into them. You guys all know this, all the crazy health conditions and infectious processes that are associated with using dirty needles or sharing needles. And then you guys might be able to answer this. I've tried to contact the Board of Pharmacy. Does anybody prescribe clean syringes to their patients? Any of you guys do this? Or are able to do it? Maybe know.
I'm a pharmacist.
Okay, sweet.
If we received a prescription for syringes, it would be filled, and
Okay.
we wouldn't have to put the indication on.
Okay. Okay, perfect.
We can sell them over the counter, like you mentioned.
Right. Okay, so that's, if that's something you guys would be willing to do or interested in doing, that's a huge step in helping people kind of reduce their risk there. Huge step in harm reduction. The other thing we want to talk to you about, another big intervention you guys can do is naloxone. Oh yeah, go for it.
I just have a quick question.
Yeah.
So if we're prescribing syringes for these patients, how are we making sure that they're being disposed of properly?
Yeah, that's a really good question. So we struggle with this on a day-to-day basis. Our exchange rate right now is 44%. So like for every 100 needles we give out, we only get 44 back. And then we've started actually like going out and walking the alleys in the north side and picking up syringes because they're definitely there. We give out disposal boxes and try to get people to come bring them back to us, but it's a struggle. It definitely is. So
Yeah, and that other slide, there was new legislation passed that protects people that work for syringe exchange programs but doesn't protect the participants. So taking the sterile supplies from our office is no problem. People feel very comfortable doing that. But as soon as there is drug residue in that syringe, they can get in legal trouble. So that is why it is difficult to get people to bring back their used rigs. A lot of people do, and a lot of people feel very comfortable doing it, especially in Missoula, where we have very good open lines of communication with our law enforcement. The chief of police is super supportive. 2 of the head narcotics officers are super supportive, the sheriff's department, and the mayor. But especially if someone has been in legal trouble in the past, they're pretty hesitant. So we do a lot of education on, if you're not going to bring your used supplies back to us, this is what you need to do. And this is what like Republic Services would tell people, the trash people. And it's pretty much, hard plastic container.
like detergent, like laundry detergent bottle.
With a secure lid that you can duct tape, and then you could dispose of it that way. So that is a message that you could, if you were to prescribe syringes to people, you would also want to either offer a disposal container, let them know they can come to us, or just do that education on where to properly dispose and how to do it.
It's kind of a tough problem, and it's frustrating for us for sure. But just kind of educating them on like, if you don't feel comfortable bringing them to a disposal area, then like, here's what you can do. It's not ideal, but it's better than just like tossing them on the street. Any other questions on that? Okay. So naloxone, I'm sure you guys have heard about this a million times, but we really want to push this. So since 2000, over 500,000 people have died of opiate overdoses. I just heard a thing on NPR last night. Like, it's like increasing by an insane percentage of people who are dying of overdoses. And I think this this discussion is really only like fruitful if you're having open communication about what your patient is injecting. So you need to kind of have that discussion. And a lot of people are injecting meth, like they'll tell us like their primary drug is meth, like they're injecting meth, and that's like how they would like identify, I guess. But then if you pry deeper, they're also occasionally, like if they can get their hands on heroin, they'll inject that too. And so, and I'm surprised by how many people inject both. So I think that puts them at even higher risk of overdose, because if they're only infrequently doing heroin, their tolerance is super low. Puts them in really high risk. So having a discussion with them on naloxone, what an overdose looks like, how to use it is really important. And then, so the American Medical Association just released like some guidelines. I don't know if they're like glorified guidelines, but like encouraging providers to do these 6 steps, and I have them in here later, to reduce opioid overdose deaths. And one of them is co-prescription of Narcan whenever you prescribe an opiate. And the caveat that they have in there is like for anyone at risk of overdose. But I think you could really easily make the case that anyone who has their hands on opiates is at pretty high risk for overdose. So that's one thing we would really encourage you guys to do is co-prescribe naloxone whenever you give someone an opiate. They can get it without a prescription at a pharmacy. We've heard though it's like anywhere from $40 to $90 for the 2 milliliter doses. And the price is just increasing. I heard another story about that yesterday, actually. The price, the drug companies are really amping up the price.
Gouging big time because
Yeah.
where we are with this epidemic, more people need naloxone,
Yeah.
so it's increasingly more and more expensive.
Yeah, and if you guys can prescribe it, the Medicaid copay is like $2 to $4. So it's super helpful for the patient and like super helpful for the community as a whole, and then really helpful for us. We give it out, but we're a small nonprofit, so any help we can get is huge. So does anybody co-prescribe naloxone with opiates? Or have heard of doing that?
We actually have a clinical pharmacist.
Okay,
That's our naloxone.
okay, awesome.
Prescriptions.
Okay, perfect. Okay, and then I think I kind of put this as like an afterthought, but it's definitely not an afterthought. Mental health referrals are really important for this population. They're at a much higher, like up to 5 times higher risk of suicide. And then there's a new paper that fairly recently came out saying that people who are injecting amphetamines are even at a higher risk of suicide. So just making these mental health referrals, which I'm sure you guys are already doing, before a crisis sets in will improve patient outcomes, as I'm sure you know. So I can't overemphasize the mental health referrals part of this.
And just a little side note on that is we ask people when they enroll in our program if they have ever been diagnosed with a mental health disorder, and it's astonishing how many people have co-occurring substance use and abuse disorders and mental health disorders. A lot of people that we see are self-medicating.
And then if you kind of get stuck and don't, like they're not really receptive to your suggestions, which happens and is totally okay, but if you're just kind of like at a loss for things to talk about, other things would be like safe injection practices, like maybe like injecting your arm is safer than your groin or your neck or things like that. How to find arteries, or how to find veins and avoid arteries. A lot of people, surprisingly, a lot of people will come in and they've like always had like a friend inject for them, and they're like, I don't know how to do this. Can you show me how to like inject? And it's kind of scary. So just empowering people to kind of be in charge of their own drug use, not necessarily do it alone because that's not safe either, but just to be able to do it themselves and be in charge of their own use, I think is really powerful. And then just talking maybe about like abscess monitoring. We see so many people with abscesses due to missed hits, and just like they don't know like like a fever might be connected with an abscess. Like maybe they don't understand that. So kind of talking to them about like when they need to seek medical attention, like if they start seeing like systemic effects of that, or how to like self-monitor an abscess. Signs of overdose. I would always astonish me how many people don't really know what that looks like. You ask them like, have you ever witnessed an overdose, and they have like no idea. So just talking to like CNS depression and like what that looks like. And then, just when to seek medical attention. There's all sorts of health problems associated with injection drug use. So kind of just talking about the signs of those, I think, is really important. And then let's see. else? Oh, and then I just added this slide about AMA's like recommendations. This is, pertaining specifically to the opioid crisis, but I think a lot of it is applicable to any sort of substance use disorder. And then if you guys are interested, here's a couple resources that we use frequently at Open Aid Alliance. This manual in particular, the PDF is available on our website, but it's really interesting. It's written by drug users, for drug users, and just kind of talks about all these bizarre things that you would never think about. And it's just interesting because it's something that I, and probably you guys never really frequently encounter in our day-to-day lives, like all the struggles that people who inject drugs have to go through. And yeah, I think that's kind of all the structured material I have to go through. But we kind of just wanted to open it up for discussion and if you guys have any feedback for us or anything like that. Questions?
Yeah, so you talked about the continuum of drug use, not necessarily just being abstinence or very extreme use. And besides using clean needles and decreasing the amount or the frequency of injecting, are there other sort of safe, behaviors that can make their drug use safer or kind of start to trend down that you would, just I guess some more examples for us?
Certainly. I mean, one thing, and it's all so individualized too with, we're all about meeting people exactly where they're at. And so, some people don't really want any advice about their drug use or anything, but we do encounter a lot of people who would like to taper and, and slow down and stop using, and we can kind of guide them in those ways. Also, even just connecting, a big part of what we do is connecting people to other services. Medical care, enrolling in health insurance is a big one. And if we're talking about just harm reduction in general, one of the best things that we can do for our population is to connect them to good medical care and to make sure that they have not only their physical being taken care of, but also their mental and emotional health is really important. And those things have been kind of proven to really be effective in helping someone work towards stopping completely with their drug use. So there are so many different strategies. Like I said, it's kind of an individual basis based on what someone needs in the moment. I don't know, Greta might have some more feedback about that.
Yeah, but my understanding, because you are a federally funded clinic, you can't start people on Suboxone, but you can continue them on it. Is that the case? Does anybody? Dr. Montel?
It's just a matter of Suboxone needs to go through what's called the DA 2000 waiver.
Okay.
So you need to get an 8 hours of special training to be able to prescribe it. It doesn't have anything to do with FQHC.
Okay.
But our issue here is just getting all the resources up and running.
Yeah. So I mean, we advocate for Suboxone and medicated assisted treatment. So if that's something you guys would be interested in doing, it's really rewarding work, I think, and it's, I think keeping in mind that maybe, you can have an end goal of maybe someone who's a chronic user, maybe someday being clean and free of drugs, but the practicality is that a lot of people who are struggling with substance use disorders will struggle for their whole life. And, maybe maybe Suboxone is not the cure and it's not going to end all of their struggles, but it will make them, it'll allow them to sort of enjoy life and have a good life and maybe be safer and not die prematurely. So I think, it's a super important thing if you guys have any interest in getting into that.
I would add that treating people with substance use disorders probably is one of the most challenging aspects that I've ever faced in my medical career. But when you start getting some successes, it's also the most rewarding. And if you really want to challenge your clinical acumen, I think of it as medicine a cappella, because it's just you and the patient, and all you have are your wits and your ability to use all the things that you've worked with, such as motivational interviewing, and mindfulness and getting them going in the right directions. And it's really a challenge, and I would challenge all of you to try it, to make it part of your career.
And I would kind of add on to that as, you know, the syringe exchange, yes, we distribute and we dispose supplies, but it is so much bigger than that when, you know, I think the benefit, the biggest benefit of the syringe exchange program is that there's a place where people can come in and talk freely about their drug use and not feel like they're being judged. And they don't feel that shame and that guilt that they're carrying around with them all the time, 24/7. When they come into our office, they know that it's a place where they can really be who they are. And I think that as providers, that's something that you can offer too, if you really want to and you really work at it. And like I said, it's, yes, disposal, yes, it's distribution, but it's much, much more than that.
And it feels uncomfortable at first, kind of being an advocate for someone who's like injecting drugs, but it's really rewarding, and I think it will, you know, ultimately end in better outcomes for the patient. So yeah, that's my.
Mark's also talked with me about thinking about it from a community impact perspective too, when if you're boarding in that way also.
Yeah.
It's helpful as a resource to your own community.
Yeah, I would agree.
Sure.
All right, any other questions?
So you were talking about going ahead and educating patients about, you know, various places to inject and stuff like that. How do you differentiate between educating them to prevent illnesses and enabling the patient to inject drugs?
Yeah. Yeah, it's hard because sometimes I think you get kind of bogged down, like when I'm working in the syringe exchange, like you kind of get exhausted and you're like, am I just like enabling people to keep using drugs? But I think just kind of being mindful that like maybe like stopping or reducing their use is not where they're at. So like the only place that you can really improve is like trying to just like keep them safe and keeping them from like overdosing or dying. So I don't know, I just try to focus on that, and like what they need in that moment is maybe not help getting to treatment, but just like help trying to like make it through the next month or whatever. So I don't know, do you have any?
Yeah, and I think that enabling piece, you know, the truth is, you know, with addiction, we know that if someone is in the throes of an addiction and they're injecting drugs, you know, they're really not going to stop until they're ready. And what's going to happen is they're going to reuse their needle, they're going to share their needle, they're going to be doing it in an unsafe manner. And so that's where we come in, is, you know, we're that place to keep them as safe and healthy as possible until they're ready to stop. And yeah, we're enabling people, but we're enabling them to be as healthy as possible while they're still using drugs.
What is the easiest way to get a hold of you guys?
Oh, sorry, I have cards to pass around. These are for our syringe exchange. We hand these out to like syringe exchange participants. So they have our number on them, and you can also hand them out to like patients or like, you know, keep them around or whatever. So I'll just pass the box around.
You can also, I mean, I have some of my cards as well. I mean, feel free, if any of you have like more questions after we leave, feel free to email me or call me directly at Open Aid Alliance. We've got a really small office, so it's never hard to get a hold of someone. And also, if you are interested in harm reduction, feel free to stop by our office and look at the space, and you know, we can give you a little tour and show you the actual syringe exchange, and maybe talk a little more in depth about some of these things.
Where are you guys located?
1500 West Broadway. So we're right on the intersection of Russell and Broadway.
It's right across the street from the cat.
Cats
on Broadway.
That's like my favorite. I mean, as far as like a business name in Missoula, that's my favorite. So,
I guess in terms of my contact question, is the easiest way in terms of the social work aspects, like housing resources for patients that are HIV positive? I have a couple, and Jana ends up helping me a lot in getting me connected. Is that the easiest way to do things?
Yeah, I would say if you have a patient who is living with HIV with housing needs, contacting us directly, absolutely cool. We work really closely with Barb Schott. So really closely. So and Deborah, who she's our housing case manager, so she would be your contact person. But her and Barb's are sweet. Like they talk like 4 or 5 times a day. So
Thank you.
yeah, you're welcome.
All right.
Well, thank you for
Yes,
listening,
thank you,
and I
guys.
hope that you learned something.
Thank you so much. Thanks for your work.